So today we'll discuss Kawasaki. Okay. So what is Kawasaki? It's a it's a motorbike brand. Okay. Okay. It's a type of vasculitis, right? So it's named after Dr. Kawasaki. Okay. He's a Japanese physician, and he was the one who recognized this disease pattern. So it's named after Dr. Kawasaki. Okay. Now, why is it important to know about Kawasaki? It's not important just for the pediatricians, but even for, family physicians and even for internists, because once a patient develops Kawasaki, even during pediatric age group, when they grow older, they have long-term consequences too, right? So it's important to know what to look for and what kind of problems they have. Okay, if the medical students say, "Oh, I'm not interested in, Kawasaki because I'm not doing pediatrics," even if they're going to internal medicine, it will be very useful. Okay, so how do you make the diagnosis of Kawasaki? It's a clinical diagnosis. Very good. Okay, so basically, it's a clinical diagnosis. When you say clinical, what does it mean? You make the diagnosis based on history and physical examination. Okay, so just keep that in mind, because most of the time we get called in the middle of the night saying that, "Oh, we have a kid with Kawasaki and we want the cardiologist to come and diagnose Kawasaki by echo." Okay, it doesn't work like that. Okay, so it's a clinical diagnosis. So having said that, so what are the clinical criteria to make the diagnosis of Kawasaki? There are mainly 5, right? Okay, so what's the first criteria?
Fever for more than 5 days.
Fever. We'll cover each in a minute, but let's first cover all the clinical criteria.
Mucosal involvement.
What's that?
Mucosal involvement, like conjunctivitis or mucositis. Mucositis, that's the word.
Okay.
Edema,
Rash.
peripheral edema.
That's not one of the criteria, though.
So rash.
Mhm.
Rash.
Good. Rash. Good.
Mhm. That's part of the mucositis.
And involvement of the
Mucosa.
extremities.
Uh-huh.
Okay, there are other criteria also, but these are the main criteria we use to make the diagnosis of Kawasaki. Okay, so what is the unique thing about fever in patients with Kawasaki? We have a lot of patients with the same clinical presentation, right? So we don't diagnose them as Kawasaki, right? We'll come to the differential diagnosis of Kawasaki, okay, in a minute. So what are the unique features of fever in Kawasaki?
High fever.
It's very high fever. It's like more than 104 and stuff like that, right? And what's the other criteria?
More than 5 days.
More than 5 days.
Very good. And what else?
Not explained by any other condition.
Okay. And they usually don't respond to regular antipyretic medications. Okay? So that's about fever in Kawasaki. It's very high fever for more than 5 days or more, and they usually don't respond to your regular antipyretic medications. Okay? Now coming to conjunctivitis. What is the unique thing about conjunctivitis in Kawasaki?
Bilateral redness.
No
Good.
infection. No infections.
It's bilateral. And the other important thing is?
Non-purulent.
Very good.
Yeah.
It's non-purulent. So if you see patients with Kawasaki, the type of conjunctivitis they have, they'll have red eyes, okay, and they'll have clear discharge, but it's not mucopurulent, and it's bilateral, okay. So that's about conjunctivitis in patients with Kawasaki. What about the rash? You have maculopapular type of rash, right? And where does it usually present? What's that?
The trunk.
Yeah,
over?
it's usually on the trunk area. Okay, so it's important. That's why you have to undress them appropriately. Otherwise, you can miss these rashes, and especially in small children, you should also pay attention to the diaper area. Sometimes you may just see, especially in males, you may just see those kind of rashes in the meatal area. Okay, so that's why it's important to undress them appropriately and examine them thoroughly. Okay, and what about lymphadenopathy? Which lymph nodes are predominantly involved?
Cervical.
And when is it significant?
When it's more than 2 centimeters, 1.5.
Okay, so you'll have cervical lymphadenopathy, and usually it's more than 1.5 centimeters. And the next thing is the extremities. Like you guys said, you can have peeling of the skin, okay? Peeling of the skin on the palms and soles, and also you can have edema, okay? And all of those come under extremities. And along with that, you can have strawberry tongue and all of those other findings. There's another important finding in patients with Kawasaki, which is very, very consistent. What is that?
Coronary artery aneurysm?
Clinically, right? Okay? If you see patients with Kawasaki, they're very irritable. Okay? So they're always kicking around, very frigidity, very uncomfortable. You know, there's so many names given to these patients. You know, sometimes we call them like, oh, they're not disciplined by their parents, and all kinds of names are given to them. It's not the child, it's the disease process itself. Okay? It's very consistent with patients with Kawasaki. Usually, when you have kids, when you have these kind of clinical presentation, how do they look? They're very listless. They're just tired. They don't want to talk to you. They're just lying in their bed, right? But in patients with Kawasaki, they're so irritable. You try to go and examine them, they'll literally kick you off, right? They're all over the place. You can't do blood work. They're so uncomfortable, right? Why is that? Why are they so irritable? Okay, the reason is most patients who have Kawasaki, they tend to have cerebral vasculitis. So they tend to have headaches. So since they have quite significant headaches, they can't verbalize, they manifest in the form of being very irritable. Okay, and also they have some degree of aseptic meningitis. Okay, so all this both put together, it makes them feel very uncomfortable because they tend to have headaches. Because they can't verbalize, they just manifest in the form of being very uncomfortable. Is that clear?
Yeah.
So this is your clinical presentation, right? So now coming back to, does this work colors? Oh, it does. Any questions? Okay, now coming to etiology. Okay, so what is the cause for Kawasaki? Do we know? Is it viral? Is it bacterial? Is it
We presume that
anything?
it's a complication from a viral infection, but there is no known cause.
Exactly. So we still don't know what the etiology of Kawasaki is. We presume it is autoimmune, but we haven't able to pinpoint any of the specific markers which we know till date as to the cause of Kawasaki. Okay. Now, coming to a little bit of the demographics of Kawasaki. Which patient population is it more common?
Asians?
Asians, right? It's more common among Asians. Even in United States, okay, it's very common among people of Asian descent, okay? And by the way, Kawasaki is one of the commonest cause of acquired heart disease in United States among children, okay? So that's why it's very important to know Kawasaki, okay? So it's more common among Asian descent, okay? And which age group is it more common?
2 to 5.
Exactly. Anywhere between 2 to 5 to 6 years. Okay? And which sex is more common, males or females?
Males.
Okay. So it's more common among males compared to, what's that?
But always
Always, right?
the weak sex.
Right. Okay. And which time of the year is it more common?
Winter.
It's usually between fall to spring. Okay. So from now on until the spring season is usually more common. Having said that, you can have Kawasaki any time of the year, but it's slightly more prone during this time of the year. Okay, so that's about thing. And also, if one of the siblings have Kawasaki, if you have other siblings in this age group, they're also prone to get Kawasaki. It's about 5%, 3 to 5% more among siblings. Okay, if you're having twins, especially identical, it's about 10 to 30%. Okay, so that's about a little bit of our demographics of Kawasaki. Okay, any questions? Okay, so now there are different stages of Kawasaki. Okay, what are those stages? You have 4 stages. The first is acute. Second is
Convalescent.
exactly. And chronic. Okay, so stage 1 is acute. When do you say somebody has acute stage? Anywhere from 0 to 14 days. Okay, is acute stage. Stage 2, 14 to 21 days. Okay, stage 3 is 21 to 6 weeks. Okay, so chronic is more than 6 weeks. Okay, so this is your different stages of Kawasaki. It's important to know. Now, among this, which stage why is it so much importance given to Kawasaki? Like I said, it is one of the commonest acquired cause of heart disease in United States, right? So what cardiac causes do you have in Kawasaki? Or what cardiac involvements do you have in Kawasaki?
Coronary
Coronary aneurysm.
Okay. You have coronary artery involvement in the form of aneurysmal dilation. Anything else?
Myocarditis.
Myocardial infarction.
Not so much
Myocarditis.
infarction.
Myocarditis.
Yeah, that's why that comes under chronic. Okay, that's why I said you can have, even the adults need to know about this because they're more prone, but that happens very later on in life. Okay, it's very rare to have myocardial infarctions in any of these stages. Okay, so any other thing which you can, cardiac involvements you can have in Kawasaki other than coronary arteries? Myocarditis, pericarditis, and even endocarditis. So basically you can have involvement of all the 3 layers of the heart. We'll talk about that in detail as we go along. Okay, but I'm just trying to bring that up because just don't be stuck up when Kawasaki just causing coronary artery involvement. It can affect all the 3 layers of the heart. Okay, so in acute stage, or let me go back. So when do the coronary arteries get involved? In the acute, subacute, or 3rd and 4th stage? Which stage do coronary arteries get involved?
Acute and convalescent.
No.
Subacute.
Okay, it's in the 2nd week of illness. Okay, from after 2 weeks onwards, that's where you tend to see coronary artery involvement. Okay, So this is where. So in acute stages, you can have any of those three layers involved. You can have pericardial involvement, myocardial involvement, and endocardial involvement. And that can happen in acute stage also. Okay? Is that clear as far as the staging is concerned? Okay. So
Okay.
now,
Come here now. Okay. Bye.
based on the history,
Sorry, doc. I have a spastic section.
oh, okay, sure. Don't worry, we're recording this for you. Okay. Okay. Oops. Oh. Let's fix this before. That's right. Okay. So now you've made the diagnosis clinically. For example, you have a 4-year-old kid, okay, who's presenting to the ER with high fever lasting for about 5 to 6 days, right? And you have all those clinical criteria which we just discussed. Fever, has bilateral conjunctivitis, maculopapular rash on the back, very irritable kid. So based on your history, based on your physical exam, you make the diagnosis of Kawasaki. Now, what do you do in order to supplement your clinical suspicion? Is there any workup you want to do? Yes? What do you want to do?
Yes,
Okay. Anything else?
ESR, CBC, toning.
You want to do CBC? How does that help you?
I don't see how it would help if it's just inflammation.
Hmm?
If we're saying that it's most likely caused by something viral,
Did we say it is viral?
well, we said that we don't know the cause.
Oh, okay.
But
Mm-hmm.
Just to rule out the other infections like bacterial by.
Can you say that based on the CBC?
no.
No. Right? So how does CBC help you?
Because
Is it important to do CBC? It is.
There's
Yes.
something
Okay.
about,
So why?
platelets.
Good. Okay. So for a couple of reasons. Okay. So you want to look for what the hemoglobin and hematocrit is. Why? If a patient has anemia, and on top of that, if they have Kawasaki, they're more prone for coronary artery involvement. Okay? So that's why it's important to know what your hemoglobin levels are. Okay? And your hematocrit. And also, like you said, what will happen to your platelets in patients with Kawasaki?
They go down at the beginning.
Hmm?
In the acute phase, they tend to go down, but then later in the disease, they go up.
They develop thrombocytosis. Okay? Their platelets level are very high. Okay? To the point they're in thousands. Okay? Maybe 800 or maybe in thousands. Right? So you develop thrombocytosis. So you want to see what your platelet levels are. Okay? So, and when do you see thrombocytosis? In which stage of Kawasaki? Stage 1, 2, 3, chronic. Which stage do you normally see thrombocytosis?
Two.
Exactly. Okay? So all the big actions are happening in subacute stage or in stage 2 from 2 weeks onwards. Okay? So, but you still want to have your baseline, and if they're very high, that will help you in confirming your diagnosis. Okay? So that's about your CBC. What else? Right? All these are inflammatory markers, so obviously you expect them to be very high. Okay? Yeah, ESR will be in hundreds, CRP will be like 50, 80, whatever the case may be, depending on how bad the Kawasaki is. Okay? So, anything else? Any other blood work you want to do? Do you want to do LFTs? Yes? Yeah. Okay. Why? Again, it's more for prognostic reasons. So if you have patients who have low albumin levels or decreased protein levels, okay, hypoproteinemia, those patients also are very prone for developing coronary artery involvement. Okay, so that's why it's important to know what the protein levels are or what your albumin level is. Okay, anything else you want to do?
Basic coagulation profile.
That usually doesn't help in terms of, because we already have this one, which will tell you what the level of your viscosity of your blood will be. We can discuss that in the management. Okay. Anything else you want to do in terms of cardiac workup now? Anything? You want to do EKG?
Yes.
Why? How does EKG help you?
To see if there's any myocardial infarction.
Was that?
To rule out myocardial infarction.
Do you expect that in
No.
our population? Like I just told you,
Yeah.
it's usually seen. If at all, if there's coronary artery aneurysm and if it's not treated, then you develop all these problems, which are all chronic problems. In acute stages, or even in the first 6 stages of disease process, why is this important?
Is it to see if there's any strain?
Again, it's very unlikely, right? So the reason why you want to do is, first of all, you want to have a baseline EKG in case if they develop any, like you guys talked about, coronary artery stenosis or ischemic changes and whatnot, you have something to compare with. So you want to have a baseline EKG. Any other reason? What will happen if do you see any changes when you have pericarditis?
Oh, like do they have diffuse ST elevation?
Right. So if you have pericardial involvement, you can have ST segment elevation, PR segment depression, right? And if you have myocardial involvement, what would you see?
Hypertrophy.
On EKGs acutely, you can see ectopic beats, you can have arrhythmias, right? And you can have ST segment T wave changes, changes on the EKG, okay? So to know what the rhythm is, to have the baseline, and to rule out all of these causes, you want to have a baseline EKG, okay? Anything else you want to do after this? Okay. Echocardiogram. So what are the things you want to look for on the echo?
Diameter of the coronary artery.
Okay, obviously you want to look for coronary arteries, right? Anything else? Obviously, like I told you, it's not just the coronary arteries which are involved in patients with Kawasaki, right? So you can make the diagnosis of pericarditis, if you can have effusions, right? Myocarditis. If you have myocarditis, what findings do you see on echo? You have very poor function, okay? Your ejection fraction is very low. Okay, and you can also look for any endocardial involvement in the form of regurgitation. You can have mitral regurg, aortic regurg, all of those. Okay, so that's why we do echocardiogram. Okay, any questions as far as the workup is concerned?
This is more like a prognostic workup, though. This is because we're diagnosing clinically.
Mm-hmm.
So this is kind of like after we've diagnosed. This
Exactly.
Is to continue. Okay.
Yeah, if you have any of those with that clinical presentation, then obviously it will supplement your clinical suspicion, right? Because you have a lot of other disease processes which can present with the same clinical presentation: Rocky Mountain spotted fever, Stevens-Johnson syndrome, allergies, right? You can have rheumatological diseases which can present with more or less the same kind of clinical presentation. So you have a big laundry list of differential diagnosis. Along with your along with your clinical presentation, if you have any of these findings which are quite specific to Kawasaki, it will help you in supplementing your clinical judgment. Okay? So now coming to echo. Any questions? Any other questions?
You mentioned aseptic meningitis. Is
Mhm.
that not included in the workup?
Good question, right? So what other things you can have in patients with Kawasaki? One is aseptic meningitis. What does aseptic meningitis mean?
Inflammation of the meninges.
Mm-hmm. And what else? What does aseptic mean? Okay, meaning when you do a lumbar puncture and you send the CSF for analysis, right, you will have all the markers of meningitis based on your chemical analysis of your CSF. But you won't be able to grow anything from that. That's why it's called aseptic. So since we already know that they are prone for aseptic meningitis and there's no etiology for that, it's not easy to do lumbar punctures on patients with Kawasaki because they're already very irritable. When you try to bend them over and try to get a clean TAM, it's almost impossible in those patients unless you sedate them, which is not gonna, it's not a good idea and it's not gonna help you in terms of your diagnosis. And what else can you have other than aseptic meningitis? Do you want to do anything to do with urine? Okay, same thing. Okay, you can have aseptic urethritis. Okay, when you send the urine for analysis, you'll have all the chemical markers for urine infection, but you won't be able to grow any bug from the urine. Okay, so all these are features of Kawasaki. Okay. Any other questions? Oh, now coming to echocardiogram findings. Okay. Now coming to cardiac involvement. So we already mentioned what cardiac involvements you can have in Kawasaki, right? So if you have pericarditis, right? So what will you see on echo? You'll see pericardial effusion. Okay, that's how we make the diagnosis of pericarditis on echo, because you have inflammation outside the heart, right? And it presents itself in the form of pericardial effusion. And when you see fluid surrounding the heart, which is very easy to make the diagnosis on echocardiogram, we say this patient has pericardial involvement. Okay. That's about pericarditis. And for myocarditis, like I said, what is myocarditis? It's involvement of your myocardial fibers itself, the myocardium itself, right? So if you have, you'll have effusion and you have pericarditis. When you have myocarditis, you'll have decreased ejection fraction, right? So your ejection fraction will be in 30s, 40s, depending on the severity of Kawasaki. Okay, that's how we make the diagnosis of myocarditis. When you have endocarditis, you'll have involvement of your valves, your mitral, specifically your mitral and the aortic valve. And what do you see? You'll see mitral and aortic valve regurgitation. Okay, so that's about your 3 layers. Now coming to coronary arteries. How many coronary arteries do we have? What's that? Mainly we have right and left. Right? So what happens to these coronary arteries? I'll just get rid of this for now. Okay? So this is your aortic valve. This is your normal looking aortic valve en face, meaning if you see the aortic valve in cross section, this is exactly how it looks. And we describe them as inverted Mercedes-Benz sign because they have 3 cusps, 1, 2, and 3. This is called the left coronary cusp, right coronary cusp, and non-coronary cusp. Okay, so your left main coronary artery comes off from left coronary cusp, and your right coronary artery comes off from a right coronary cusp like that. Okay, so this is your left main, this is your right coronary artery. Okay, so of this, which is more commonly involved, the left or the right? Okay, it's slightly more in the left as compared to the right. Okay, and which segment of the coronaries are involved? Is it the left main coronary, the circumflex, or the left anterior descending, or what? It's usually the proximal segments. Okay, that's why echocardiograms are useful. Okay, because if it's distal, it's very difficult to see the distal part of the coronary arteries on echocardiogram. So this is how you tend to have when they have coronary artery aneurysms. Okay, you can have different types of coronary artery aneurysm. You can have saccular type, fusiform type, all kinds of, or just one part of the coronary artery is involved and stuff like that. But usually this is how they look. Okay, so it's very rare to have just this distal segment involvement and sparing the proximal segment. Okay, if you have proximal, you can also have distal segment involvement also. Okay, but just having distal sparing the proximal is very unusual, very unlikely. That's why echocardiograms are useful in making the diagnosis. Is that clear?
Yeah.
Okay. Now, when did these coronary arteries get involved? In which stage of the disease process? Okay, remember that. Okay, so when you call a pediatric cardiologist to do an echo to make the diagnosis, especially if the patient is like 6th or 7th day of illness, if you do an echo, do you expect the coronaries to be involved?
No.
Very unlikely. Okay, unless you have atypical presentation where you have, you don't see all the clinical presentations of Kawasaki, but you see coronary artery aneurysms, then we call that as atypical Kawasaki. In those cases, very rarely it might be helpful. But in most typical cases of Kawasaki, you will not see coronary artery involvement, at least in the second week of illness, okay, in the second stage. Okay. Any questions as far as the coronary arteries are concerned? Okay. Again, depending on the size of the coronary arteries, aneurysm, we say it's mild, moderate, or large aneurysm. Okay, and that's based on the body surface area of the child. Okay, we have some, the markers where we have normal Z-scores for those particular size of the coronary arteries, depending on the age of the patient, the size of the patient, the height and weight. Okay, but for most purpose, when you have if you have small, it's usually from more than or equal to 4 to 6 centimeters. Okay, millimeters. Centimeters will be huge, right? Okay, and moderate will be 6 to 8. And large or giant aneurysms is more than 8. Okay, so this is how we stratify them or diagnose them based on the size of the aneurysmal dilation. Is it clear? Okay, so that's about your diagnosis. Okay, so we know the history, we covered the physical examination, the different stages, the kind of workup we need to do, and what cardiac involvements you can have in these patients. Okay, so now we have made the diagnosis of Kawasaki based on all your tools you have. So now, what's the next stage? You want to treat these patients, right? How do you treat these patients? What's that? IVIG and aspirin. Okay, so how do you give IVIG? Sorry, Nisa, you need to. How do you give IVIG?
2 milligrams per kilo.
Obviously, it's a kind of a stupid question, right? It's given as IV, right? But how is it given? Is it given like antibiotics, like we push? IV antibiotics?
4 hours can be given.
Exactly. It is given very slowly as a slow infusion. Okay? So, for how long is it run? It's institutional based. Some institute, they use up to 8 hours, some from 10 to 12 hours. Okay? So, it's given as very slow infusion. Okay? And what's the dose?
2?
Milligrams per kilo.
How much?
1 to 2 milligrams per kilo.
No.
2 milligrams per kilo.
2
No.
grams.
Grams.
1 to gram. 1 to 2 grams.
Not 1, 2. It's 2 grams
2 grams per
per kilo. Okay? That's your dose. Remember that. Okay? It's 2 grams per kilogram. And it is given as slow infusion. Okay? Since it's a blood product, okay, you can develop the same side effects or reactions like you can have when you're giving blood transfusions, right? So usually what we do, we pre-medicate them with Tylenol and Benadryl for half an hour before you start the infusion. Okay? Now, when do you want to give IVIG? In terms of timing, okay? As soon as you make the diagnosis, you have to treat with IVIG. Why? Because IVIG is the only known medication which is known to protect the coronary arteries till date. Okay? So it's important to give IVIG. And the best response is given when it is given in the first 10 days of illness. Okay? 10 to 12 days of illness. Okay? So you get the best response when it's given earlier on during the disease process. Okay? So, and what is the other treatment you want to give? Aspirin. Right? And how much of aspirin do you want to give?
Higher dose.
High dose, right? So what is considered high dose? What is considered a high dose? 80 to 100 milligrams per kilogram per day in divided doses. Okay? So say the kid is 10 kilos and you want to use 100 milligrams, it's 1,000, and you divide that, say every 6 hours, so 4 times a day. Is that clear? Okay. So nowadays, the recent papers have shown that instead of giving high dose, you can just use low dose to begin with, even from the start. Okay. But during the old school, or even now for most cardiologists, we still stick to giving high dose aspirin initially. For how long do you want to continue high dose aspirin? Or before that, how do you know if your patient is responding to your medication?
Because fever stops.
Okay, good. So it's the fever. Fever is your indicator. Okay. So once you have completed your IVIG infusion, you should start to see defervescence of fever in the next 24 hours. Okay. The kid might not become totally afebrile, but you'll start to see the defervescence of fever. Okay. And that's when you know that your IVIG has worked. Okay. And then for how long do you want to continue with high dose aspirin?
Until fever stops.
At least for 48 to 72 hours after defervescence of fever. After the child becomes afebrile. So until then, you continue with high dose aspirin. Then what do you do with your aspirin?
Decrease the dose.
Decrease low
You
dose
decrease
like
it to low dose. Okay, now what is considered low dose?
10 to 20 milligrams per kilogram. 5 to 10.
Okay, it's 5 to 10 milligrams. Okay, now at this dose, it has anti-inflammatory effect. At this dose, it has anti-platelet effect. Okay, so that's why we reduce it to low dose aspirin. And for how long do you want to continue with low dose aspirin?
For next 8 weeks,
Hmm?
6 to 8 weeks.
So at least for 6 weeks. Okay? Why do we say at least 6 weeks? Because
But the
it,
stages.
yeah, based on our stages, so it takes at least about 6 weeks, if at all, if there is any coronary involvement beyond the second stage of illness. We do echo at 6 weeks of illness, and then if the if the coronaries are normal, then we stop the low dose aspirin. So say somebody has coronary artery aneurysm. Okay, in the second week of illness, you do an echo, you see coronary artery dilation, you have coronary artery aneurysm. Then what do you do with low dose aspirin? You stop in 6 weeks? Yeah, you have to continue aspirin indefinitely. Until what time? Like I said, indefinitely meaning until the coronary arteries resolve spontaneously. Okay? It depends on the degree of aneurysm. If you have small aneurysms, usually small to moderate, usually they resolve spontaneously in 2 years of illness. Okay? If it is large or giant aneurysms, they may not resolve spontaneously. They remain dilated. So what do you do in those patients?
You have to do echo, like,
You keep them indefinitely. And sometimes, depending on the degree of aneurysm, we not only keep them on aspirin, sometimes we may have to use other stronger blood thinners like Coumadin or low molecular weight heparin and stuff like that for life. Okay? So that's why I said, even if you guys decide to become internists or you want to become family doctors where you don't want to deal with pediatric patients, when these patients become older, you will be following this up for these reasons. Okay? And also remember, kids who develop coronary artery involvement in pediatric population, even if they have resolved spontaneously, there have been studies which have shown that as they become adults, they are more prone for premature coronary artery disease. Okay? So that's why it's important to evaluate them. Say you have a 21-year or 25-year-old, okay? It's very uncommon to have coronary artery disease in those young kids, right? And young adults, I should say, okay? So, but if you have a history of coronary artery involvement secondary to Kawasaki, these patients are more prone for coronary artery disease. They can develop coronary artery stenosis and stuff like that. So you have to evaluate them more aggressively in terms of not just EKGs and echoes. You want to do a stress test, you want to do a nuclear stress test, all kinds of, sometimes even you may need angiograms in those patients. Okay? So that's why it's important to diagnose them. Okay? Any questions as far as treatment is concerned?
How often would you follow up with them? Like once you start them on the aspirin and
Good question. Again, it depends on the degree of coronary artery involvement. Okay? Say, for example, if they have no coronary artery involvement, the coronaries were normal to begin with, and you do a 6 weeks follow-up, and you do an echo, and the coronary arteries are normal, and then we stop the low-dose aspirin, and usually we don't follow them up after that. Okay? Some maybe, some cardiologists may follow up in 3 months, just to make sure, but usually you don't need any follow-up. But if they have coronary artery involvement, again, depending on the degree of coronary artery involvement, you may need to see sometimes even monthly if they have giant aneurysm. In fact, I have a patient who has giant aneurysm, okay? And initially, I was following him up very closely, almost like on monthly basis. And then you can see them every 3 months to 6 months as they grow older, and if nothing has changed. And like I said, depending on their symptoms, depending on the presentation, you may need other imaging modalities. Like I said, you may need even angiograms for those patients. Okay, so that's how we follow them up. It all depends on the degree of involvement, cardiac involvement. Okay. Any other questions? Okay, say for example you have a 4-year-old kid who was diagnosed with Kawasaki, and you treated them appropriately, and you're sending this patient home. What's one precaution you want to tell the family or his primary care doctor?
Vaccines,
Good. What about the vaccine?
the live vaccines.
Okay. So since he's 4 years old, okay, once he has had IVIG, you've treated him with IVIG, you tell them not to give live vaccines for at least 10 months after you've treated with IVIG, because their immune system is low and they can actually develop the disease itself if you give live vaccines instead of trying to develop immunity towards it. Okay, so that's one precaution you should always tell the pediatricians and the parents when you discharge them home. Okay, now coming back to treatment. Say for example, you have treated this patient with IVIG and, and aspirin, and say after 24 hours, the fever spikes again. Then what do? And by the way, this is not uncommon. If you're dealing with patients, you'll definitely see these situations. It's not uncommon at all. So you have treated with IVIG, the patient, still continues to spike fever after 24 hours after you have treated with IVIG. Now what do?
You can do a second cycle of
Give another
IVIG.
dose of
Very
IVIG.
good. Okay, you give the second dose.
Mhm.
Same thing.
Yeah.
Same dose, 2 grams per kilogram, same duration. And what response do you look for? The same thing. You want to look for effervescence of
Fever.
fever. Okay. Say you gave the second round. Again after 24 hours, the fever is still not effervescing. It's still spiking fevers. Then what do?
Another
Hmm?
Another trial of IVIG.
Okay. So there are a couple of ways you can deal with. You can either give a third round, same dose, same infusion, or what else can you do?
Oh, you can give infliximab.
Yeah,
or-
monoclonal
What
antibodies.
else?
Yeah, you can give steroids or infliximab and all of
Mhm.
that. Okay, that's where steroids come into play in treatment of Kawasaki. Okay, before when you give, a lot of patients got steroids without realizing
Yeah.
that these patients had Kawasaki. So it was in fact initially it was contraindicated. Why? Because they thought, you're decreasing the immune system, the coronary arteries will get involved more commonly, but there was no major damage done to those patients. So that's why we know that, steroids didn't do much harm, but it didn't do any good in terms of protecting the coronaries also. So that's when we add steroids for its anti-inflammatory effect after the resistant cases of Kawasaki. Okay, so coming back to the coronary artery involvement, do all patients with Kawasaki develop coronary artery involvement
No.
Not necessarily.
even without treatment? No.
No.
Okay, so what percentage of patients develop coronary artery involvement? It's about 30%. Okay, and 30% is a big number, right? So you don't know who's going to develop them, so that's why you want to protect those 30% also. Okay, so do everybody who have IVIG are protected from coronary artery disease?
No.
No. Okay, most of them are. Okay, again, about 10% I think are the ones who will still be prone for developing coronary artery aneurysms even after treatment. That's why we follow them up until 6 weeks of period. Okay, so keep that in mind as far as the treatment. That's why IVIG is so important, because IVIG is the only medication which has known to protect the coronary arteries from developing into aneurysms. Okay, and that's why it's important to give them earlier on. So what if the patient comes to you after 2-week period? We told IVIG's best response is given in the first 10 days of illness, right? Not first 10 days from the time you make the diagnosis, right? So what if the patient comes to you in the 2nd week of illness? Exactly. You still want to give them the benefit of protecting the coronaries, okay? It may not be as much as when you give initially, but still, this is the only medication which is known. So you want to give them the benefit of protecting the coronaries even if they come after the 2nd week of illness. Okay? Any other questions? Okay. So also remember, we talked about the age range, right? Which age range is more commonly seen?
2 to 5.
2 to 5. So anybody before or after this age range, can they develop Kawasaki?
Yes.
Yeah.
Definitely. Okay? So just because it's more common in this age group, it doesn't mean the kids less than this age or more than the 5 or 6 years of age can get it. An important thing is if they develop in the infancy, in less than 6 months of age, okay, they're more prone for coronary artery aneurysms. And same with the older age group also. Okay? Even 10 or 11 years old can also develop Kawasaki. And if they do, they're more prone for coronary artery aneurysmal dilation. Okay, so keep that in mind. So you can have, anybody can get affected, but if they get affected outside this age group, you have to be more careful. Okay? Any other questions? So we covered about how to make the diagnosis, right? What the clinical presentation are, what the history is, right? What are the tools we use to supplement a clinical diagnosis, how to manage them, and the complications, right? Complications are, again, like I said, depending on the degree of coronary artery involvement. We have had kids where the coronary arteries were so markedly dilated that they needed coronary artery bypasses because they were so huge. Okay, and there were some kids who developed such huge pericardial effusions that when I was doing fellowship, we had a kid who had Kawasaki. The pericardial involvement was so huge, we literally had to leave the pigtail catheter for almost like a week to drain the fluid from his pericardial sac. It was so huge. He was almost developing into a tamponade. Okay, so that's why it's important to make all these diagnoses and treat them appropriately. And there were also some of the kids who have developed such bad myocarditis that they needed heart transplants. Okay, so it's not a trivial diagnosis. Okay, so you have to make the diagnosis in a timely fashion and treat them appropriately, and usually they do well. Okay, any questions? Any other questions? Okay, so I'll just put this. I just made my lectures on YouTube, so if you guys want to share it with somebody, or when you want to use it at different times, you can just go to YouTube and just type Dr. Quraishi, and you'll probably be able to see this lecture. I'm just using it so it'll benefit my other students and my other residents. Okay? If you have no questions, I think we're good, right?
Perfect.